Hello and welcome to Prairie Pulse. Joining us on today's show are representatives from AARP North Dakota. We have the state director, Josh Askvig. Josh, thanks for joining us.
Thanks for having us.
And the state president, Kathy Schwan.
Hi.
Kathy, thanks for joining us today. We always ask folks to tell us a little bit about yourself, maybe your background, and how you ended up where you are. Kathy, we'll start with you.
Well, I retired about 5 years ago, and my husband retired 3 years ago. I had been a longtime volunteer for AARP out of Fargo. We live in West Fargo and have 3 adult sons. So, with grandchildren too, we keep pretty busy.
I believe you do. Josh?
I'm a lifelong North Dakotan. Grew up most of my life in Minot, North Dakota. Went to undergrad out in Dickinson, and then spent some time out of state working for former Senator Conrad, and then moved back to North Dakota a few years ago and got really involved with teachers and worked on a number of retirement issues, and ended up at AARP because of our work on a bunch of different coalitions and realizing that if you can make life better for those 50 and older, you're likely making life better for pretty much everybody in the state of North Dakota. So happy to be here and appreciate you taking the time to talk.
Well, with that said, you are here to talk about caregiving in North Dakota. It's a huge issue as we have an aging population in North Dakota. Can you talk sort of about the scope of the issue?
Yeah, I think one of the things to recognize is when you realize the percentage of the population in North Dakota that is going to be over the age of 65 continues to grow and expand, and then when you realize that as your age goes up, your likelihood of needing some sort of long-term care continues to grow. Right now, we know in North Dakota, 62,100 individuals are providing approximately 60 million hours of uncompensated care a year, to the tune of almost $860 million in uncompensated care. So when you talk about the scope of the issue and the importance of the issue, and you think about our aging population, you're really talking about a good portion of North Dakotans that are helping loved ones stay safe and independent at home. And so that's folks, when we talk about family caregivers, we're talking about individuals, sometimes a friend, sometimes a spouse, sometimes a brother or neighbor, that help their loved ones perform what we call activities of daily living, or functions like sometimes as simple as shopping, sometimes as mowing their lawn or helping them with groceries, sometimes as complex feeding tube care, wound care, those types of things that allow them to stay in their homes and in their communities where they live and want to stay.
And so it's a big scope of what you tell us. But so tell me about, what is the Caregiver Advise, Record, and Enable Act?
The CARE Act, or as you aptly described, the Caregiver Advise, Record, and Enable Act, is a piece of public policy that AARP has been working on around the country. It's passed in over 38 states and 2 territories, and it really speaks to the heart of what I was talking about at the end of what family caregivers do. So family caregivers who are helping their loved ones perform some of those tasks, medical and nursing tasks, don't often get the information and resources and training they need to do so safely. So what the Caregiver Advise, Record, and Enable Act is a piece of policy that says when someone goes into the hospital, the first thing a hospital should do is help identify who's going to help that person heal when they go home, and bring that family caregiver in as a partner in that healing process, so that when they do end up going home or leave the hospital, that individual is known and a part of that process. Once they've identified it, the hospital asks the patient, do they want that person recorded? If the answer is yes, they put it in their medical chart. Then it triggers what we call 2 other key provisions. The second provision is that when that person is going to leave the hospital or leave their healing in the hospital to continue healing at home or in another facility or another location, that family caregiver or that person who's going to help them heal is made aware of when they're leaving, where they're going, why they're going where they go. From the simple standpoint of, even in North Dakota, there are still stories of family caregivers or somebody who's going to help someone show up at the hospital. That person's been discharged or sent somewhere else, or home, or somewhere else. The third piece then is what I call one of the most critical pieces. When you think about, we surveyed family caregivers 3 years ago, 67% of them said they do some sort of medical or nursing task. Most of them said they were not getting any type of instruction to do that. So they're being sent home to care for their loved ones, oftentimes with simple things. How do I move the person from a wheelchair to a bed? how do I change the wound dressing on an incision or something that so it doesn't get infected? And they're being handed a sheet of instructions, which is helpful, but they're never actually being shown or taught how to properly do that, so they do it safely, help their loved one heal, and they don't end up back in that hospital setting. And so the CARE Act has those 3 simple provisions that we think are pretty common sense to help folks get the support they need to keep their loved ones safe and independent at home. And I should tell you, John, and to the folks watching, Kathy's got some good stories I think we'll get to on why that's needed, but it's really based on some public policy research that AARP did a number of years ago that's showing increasingly folks are being asked to do these complex medical things without any assistance or training.
The CARE Act, as you call it, is 38 states and 2 territories. Is it really state by state, or federal ties into all this?
It's a national policy that AARP has worked on, but it is being worked on state by state. So North Dakota is pushing to try and become what we would call the 41st state or territory to work on it. And the reason being is the stories that Kathy and our peers hear day to day.
Well, with that said, Kathy, are you lobbying North Dakota for this right now?
We get a lot of feedback from our members as well as people that come to our events. And when the caregiving discussion took place a couple of years ago during the last session, people started volunteering issues that they've had. And they heard that hospitals were already doing this, but in reality, and I give hospitals credit because they do their best, but the issue is you're talking to an individual who is worried about, how am I going to do this when I get home? Who's going to help me? And you have either a spouse or a family member. You're kind of worried about how you're going to take, are you going to take time off from work to take care of them? So a lot of the message gets really jumbled as they're about to be discharged. In my situation, I heard all these stories, and I had a friend whose father had a stroke, so I went to the hospital with her as he's being discharged after 2 weeks. And one of the issues that I was concerned about is he was supposed to start or continue a drug called Coumadin. It's a blood thinner after a stroke. And anybody that knows anything about Coumadin, you have to take it every day, and you have to know what the dosage is that you're going to take. Well, they were discharging him with no Coumadin. He had had his dose that day, and they said, well, go find yourself a primary doctor. Well, when you're being discharged on a Saturday night, what do you do about Sunday's Coumadin? You can't just, nobody's going to just give it to you. And how long will it take to establish a primary doctor? So at that point I said, we're not leaving until we have Coumadin. And she says, well, set something up. And I said, we can't set something up on a Saturday night. The other thing is he had to be, give himself self-injections of insulin for the first time in his life. Well, we need some instruction on that too, and he was given a brochure. And the brochure, because he's not English speaking, they gave him the only non-English speaking brochure that they had. It was Spanish. He's Vietnamese. So, and I'm sure it checked off the box on the discharge planning, but it wasn't relevant to his situation. That's just my experience. And I shudder to think if he had gone home without that Coumadin. But I did get the week's worth of Coumadin before we left.
Wow. So how is the act working in the states where it already is law?
So what we know from where it is law is that what we're discovering is that hospitals and others are seeing, and caregivers are seeing the value of taking that time. The story Kathy just told about the Coumadin and about the self-injections, especially the self-injections piece, taking that little bit of time and making sure that folks understand how to do it will hopefully in the long run reduce what we call hospital readmission rates or those pieces. Now, we haven't seen enough long-term data. The neat part about this act is this has all occurred the original research was done about 3 or 4 years ago, and we've already seen this many states take this up as a best practice and are seeing the importance of bringing in family caregivers as a full part of that care planning team. And that's what we're asking for in North Dakota, is make sure that folks like Kathy don't have to fight, scratch, and claw to make sure that the loved ones they're trying to help keep safe are safe. And that's the important part of the CARE Act. And so when you ask how it's working in other states, I will tell you that in those states, what we're seeing is continued partnerships and discussions about not just the CARE Act piece of it, but how else can we make sure that those family caregivers are a part of the process to do what everyone wants to do, help patients go home, heal, be safe, and have happy and healthy, productive futures.
Well, I mean, so many times it's family care. It's not formal care. So a family member also all of a sudden becomes the caregiver, and those stories have to be tremendous out there.
You know, I can tell you another one about Robert from Bismarck. He told us that his dad has MS, and after he was in the hospital for some period of time, his father was discharged. Robert didn't know anything about having to move him, you know, his dad in bed on a regular basis to prevent bed sores. Well, he didn't, and what happened is his father developed a very significant bed sore with an infection, and he was readmitted again just for the infection. Now, that could have been, you know, information that could have been conveyed to him, and, you know, when things are written down, you have something to reference back. But if it's just a verbal, by the way, make sure you turn them on a regular basis, it's going to get lost. And in this case, that's exactly what happened.
I think that's another example of where the CARE Act would have helped then make sure that that hospital person who was helping them had spent a little bit of time to say, here's how you turn him, here's how you make sure he's sitting in the right places, how you keep moving so that this doesn't end up happening, and prevented that hospitalization.
So the CARE Act will make it specific for the discharge to tell an individual or family member or whoever what needs to be done. Is that what?
It essentially puts in what I would call a step to ensure that those identified caregivers get the instruction and demonstrations and information they need to safely perform the tasks they're being asked to perform at home.
But so why is long-term care seems to be just so expensive, and is there any way to help to get assistance for people to pay for this?
Well, one of the things that happens is if you have assets, you know, the nursing home will look at that when you're admitted, and they'll determine what your cost is going to be. And really, you pretty much have to drain your assets before you get that extra help. And once you get their extra help, they take a look at your Social Security income. And in many cases, depending on, you know, what your assets are, you get to keep about $60 out of your Social Security, whatever that might be. And then the rest goes to the nursing home, and that covers your medical as well as your medication and your care. And in North Dakota, it's in the mid-80s of those that are Medicaid recipients in nursing homes, some more than others. People who are in assisted living or any of those other kind of facilities obviously have assets where they can go into a different type of facility. But generally, the nursing homes are those that are most likely to be subject to Medicaid.
Yeah, they're about 50% on Medicaid, are Medicaid recipients in nursing homes. To the point of why is it so expensive, institutional care is generally about 3 times more expensive than to provide the same types of supports and services at a home-based setting. And so when we talk about what we're doing in the legislative session, talking about supporting folks to stay safely and independent at home, one, we know that's where they want to be. That's where they, survey after survey we've done since I've been at ARP and prior to me, says the number one concern about folks as they age is how can I stay safe and independent at home. The second thing is it's usually more cost efficient not only for the state, but also for the individuals to be able to receive that care at home. The third piece is then they can stay a part of the communities where they want to be and grow up and live and keep those dollars oftentimes right within that community rather than have to be moved as part of it. And so when you look at why is long-term care expensive, well, it's a tough job. There's no doubt about that. But it also has to do with how do you provide those services and how do you ensure that you cover those services to make sure folks can stay safe. And when you look at folks that are in institutions or nursing homes, nursing facilities, many times they're the most high need in the state. Even though we have some of the lowest the highest percentage of folks with low care needs in nursing homes, there's still high care needs and compared to other things. And we think there's things you can do to help folks stay at home longer and safer. The CARE Act, again, being one of those to help prevent folks from getting worse or needing extra levels of care.
Yeah, can you talk some more about what kind of burden it really places on sort of the children and maybe the healthier spouse?
Well, the other thing that has to be factored into this, if the person does get the extra help through Medicaid, they have to go wherever there's a bed available. And if that's clear across the other side of the state, that's what happens. And then you can see the burden on the family at that point too. But the family, they look at the resources of the individual. You know, they don't look at the resources of the child or cousin, sister, brother, whatever. The assets are of the individual, and it could be, you know, there could be a spouse still in the picture that needs those assets to live as well. So, I mean, there's a number of factors that really create an upheaval for the family when that happens. So it's best to really plan as far in advance as you can, because ultimately everybody's going to need care.
The other thing I'd add, John, is in terms of the stress it places, if you think about, I know when I think about my loved ones, and I have mostly little ones on the other end of the spectrum, but when they're sick, it stresses me out. They don't feel good, they're not acting the same way, they're not behaving like they normally would or whatnot, and so that stresses you out. Then you add in the complexity of you're probably having to perform some sort of medical cares on top of that, and you may not know how to properly do that, and so now you're worried about how is that going to impact me. Oh, by the way, a good majority of caregivers, including in North Dakota, are working, so they're now balancing their working lives, kids, and caring for their parents, in many instances parents or a loved one, and trying to juggle all of that. So now you've got that stress on top of it, which means guess what? Something's got to give. So what do they give? Probably some of their hobbies, some of those releases that they would use to de-stress, and you can see pretty quickly how things start piling up, and the stress starts adding up to a level where folks just are having a hard time balancing it. And that's one of the reasons we've continued to fight for ensuring that folks that are doing that at-home care, especially the family caregivers who are uncompensated, get those breaks or get those needed, what we call respite periods, or times to just step away and get some time away.
Yeah. Well, that said, you mentioned about medications just in one of your stories, but what about managing medication? It's a huge responsibility.
Oh, absolutely.
Yeah, I think it's the last survey data said somewhere about 61 to 67% are doing some sort of medication management in their family caregiving duties. So that's helping husband, wife, brother, sister make sure they're taking their medicine at the right time, the right doses, the right places. And while there are things to help with that, that's often one of the first things that folks notice is a need and a growing part of that. And so, again, going back to your question about stress and burden, I know I worry about taking my own medicine, right, when I have to take medicine. Now thinking about having to not prescribe it, but measure it and dole it out for somebody else certainly is a challenge as well. And then if you're not sure what it is they're being given or why they're being given because you weren't included in that full process, that can get really complex really fast. And I know we've heard some stories about some things like that as well before. So.
Yeah, and even things, you know, grapefruit juice, having a glass of grapefruit juice with a certain medication can create some really adverse effects. You can't be there to make sure the individual isn't drinking grapefruit juice. But you have to look at all those things, and I know people who on a regular basis will call their mother or their father and say, okay, it's time to take your next pill. Did they? They hope they did. But, you know, it puts an extra pressure on that individual who's working, looking at the clock. You're not waiting for the next conference call. You're wondering if mom took her pill. So, you know, the people that are in that situation, and some of those people do quit their jobs just to take care of that family member, and then they never get a break either, because that person, they need to keep them there for financial reasons and because the individual wants to stay at home. But now you kind of have two people that are in kind of a precarious situation. So it doesn't get better until we find some solutions.
Well, you may have just answered part of this question. As the population continues to age, you know, talk about the real issues, and I think you just hit on one of them, that face this country as people live longer.
Yeah, I don't think anybody anticipated that, you know, we would be living this long.
No.
I remember when I grew up, I thought 60 was old. And now being, you know, Medicare age, I kind of changed my opinion on it. But, you know, as people live longer, we just, you know, haven't really set up our environment to accommodate that. And so this is so important in order to really maximize the benefits to help people stay in their homes longer.
When we talk about aging, we talk about real possibilities, and about possibilities often expand when you age too. You know, people think about aging as diminishment and decline and that, but it's also about making, you know, your possibilities do expand in some ways. And so when you think about the challenges, I think there's opportunities as well as part of that. But one of the things I want to go back to, John, that you'd mentioned earlier about the burden on folks, it occurred to me as I was thinking through it, listening to Kathy talk a little bit about when you talk about those, one of the other burdens we haven't talked about, the financial burden it places on those families. You know, on average, folks spend about $7,000 a year out of pocket to help their loved ones stay safe and independent, whether that's at, you know, helping them again with groceries, you know, buying groceries, home type things, or oftentimes paying out of pocket for nursing care or medical expenses. If somebody has dementia, it's close to $10,000 a year out of pocket that they pay. And that's not Medicaid, that's not Medicare, that's not any assistance, that's out of their pockets that they're paying to help their loved ones stay safe and independent at home. So if you think about that on top of the other burdens as piece of it as well, and again, we talked at the front end about how our aging population continues to expand as baby boomers get older, which is a good thing, that those are some of the challenges out there.
Well, you know, y'all really hit on this, but but a lot of people think about, well, I'm on Medicare, so it covers everything. But once you go into a nursing home, it changes things.
Yeah, so two things. First thing to realize is Medicare does not cover nursing home care or long-term care. And I mean, you said that, but just to be very clear to folks that is Medicaid if you qualify for it and you don't have assets to help you fund it. The second thing is even folks who are on Medicare spend approximately about 30% of their budget on some sort of medical care, whether that be prescription drugs, whether that be deductibles, or other pieces as well. And so, you know, I've often heard when I came to work for AARP, said, "Oh, great, you work for folks that don't have to worry about medical care anymore, right?" And it's like, well, wait a minute. You know, when you dig into the facts of this and you realize that folks are still spending a good portion of their income on medical needs, even on Medicare, that's important. And then when they realize it doesn't cover anything in terms of long-term care, that's hospital with clinic care, prescription drugs, the A, B, and D parts of Medicare.
So Josh, how do we increase respite care in the state?
Yeah, you know, respite care we talked about earlier, and so the good news is this. I think there's a growing awareness that folks are working harder, spending more time caring for their loved ones and piece of it. The second piece is North Dakota was one of 2 states 2 years ago that applied for and received a grant called the Lifespan Respite Care Grant. It really looked at where are the gaps in ensuring that folks who are caring for their loved ones occurring, and how do we fill those gaps across the lifespan, whether that means you're taking care of an older individual or a younger individual. I'm proud to tell you AARP is at the lead of that work, working with the Aging Services Division and others in the state of North Dakota to really focus on how do we make sure that folks who are doing that complex, often 24/7 care, get that time away so that their break isn't going to pick up the prescription for their loved one. Their break is getting some time away to do some of those hobbies and de-stress as part of it. But I will tell you, part of that is working on making sure you have those conversations with families and supports and digging to ensure you get those things ready.
Yeah, and Kathy, expanding on that, how do we improve those outreach and resources to help those family members directly?
Yeah, I mean, there's so many aspects to that, especially the part I worry about is the rural piece in North Dakota. You know, with the 4 quadrants of the state, you've got one major city, but what about the rural area? They're the ones that really suffer, especially in areas of transportation. We heard some feedback from people that, you know, you might have someone that's still living at home, maybe they're in their 80s or 90s, but they're not able to drive. And say they have to have treatment in Grand Forks or Fargo or Minot or Bismarck, how do they get there? You know, there has to be some type of mechanism to allow for the transportation without somebody taking time off work to go get them, bring them to treatment and back. We just have to look at that piece of it too. There are some things coming with Medicare and some of the insurance companies that are kind of building in some of the transportation piece into the coverage. So, you know, we're making small improvements in those areas, but that's one, because a lot of times people just won't go.
Yeah.
They just say, I can't get there.
Yeah, And Josh, you talked about the CARE Act, but I mean, is that the most important thing, or how do we create programs to help foster that training and that education for both formal and informal?
Yeah, I think a couple of things. I think the CARE Act is probably the most critical piece, because where you often see things missed is in those transitions, and that's not just in hospital transitions. That can be transitions from anywhere to a different setting, part of it. But oftentimes they're coming home from the hospital with some sort of care needs, and so that CARE Act provides that piece as part of it too. The other thing I would tell you about increasing the awareness and outreach is discussions like this, John, have to happen not just on Prairie Public Television, but around kitchen tables around North Dakota, to talk to your family members, talk to folks in the community about what is available. Because oftentimes there may be a resource you don't know about right in your community, but if you're not having that conversation and not digging into it, and we at AARP have taken that mission to heart, we continue to try and foster discussions about how we can improve caregiver supports in North Dakota and across the state.
Okay. Well, we've done some of the conversation here, but if people want more information, Kathy, where can they go?
AARP has a great website that has links to all these different pieces, and Josh knows that link.
aarp.org/ND.
Indeed.
Yep.
Well, that's for North Dakota.
Yes.
We're out of time. Thanks so much for joining us
Thank
today.
you, John.
Thank you.
Well, that's all we have on Prairie Pulse this week. And as always, thanks for watching.
Funding provided in part by AARP, a nonprofit, nonpartisan membership association, 88,000 strong in North Dakota, and by the members of Prairie Public.